the process, reducing hands-off time, and there's some quality measures that I look at in this, and I wanted to ask you so I can see if you're actually measuring the same thing, okay? When we look at resuscitation, I know that it's been told to us time and time again through a lot of our CPR classes that high quality CPR is the key, right, to survival, correct? And what is high quality CPR? Oh, you guys got to know this. Good depth, right? What's the other one? The recoil. And oh, what's that? He said something interesting. The increase what? CPP. What is that? What does it? But without knowing like the definition, do you know what cerebral perfusion? So we're measuring actually the amount of time that we're on the chest when we're making that statement, right? I mean that's what it is. And thank you very much because that's where I wanted to go. But in one of those pieces, measuring that, American Heart Association says we needed to be at least 60% of the time on the chest, right? And that us as a system before COVID, so I'm going to use the pre and post COVID part of this, is that before COVID, we were right around 78% of the time we were on the chest as a system. So that's right there at that 80 where we always set like marks where we want to be in performance. We try to say, hey, I want to get you guys excited about this and let's get above that line. 80 is that mark and we were really close to it. When COVID happened, it kind of dropped. In fact, it got down to like 68%. Okay. But just recently, I can tell you that the trend has changed, and I don't know if it's through your own education or the ability to do so, or just having some conversations with folks and maybe even some of the tips and trends that's come out. I've recently seen where that CPP, the cerebral perfusion pressure, the hands-on time, is in the 90s. And that's great. That's sometimes hard to do, though, isn't it? Especially in what you guys are doing, and girls, in the field and where those patients are, right? Because, I mean, as the scenario we're going to do here in just a little bit, we might end up having to move our patient, which might decrease some of that. And that's really important for us when we start resuscitation, right? And then also, what's our mode? Taking care of the patient, right? And actually resuscitating where we find them. That seems to be a key piece, too. So thank you for that on that part of it. So high quality CPR, rate, depth, amount of hands-on time. The rates have changed over the past 5 years. What they say now? They always gave us a minimum, but they never gave us an upper limit. And I'll be honest with you, most chest compressions that I had seen from our first responder groups a lot of times was about 150, 160 compressions a minute. So it's kind of fast, right? So definitely decreasing ventricular filling times, right? Which meant the amount of blood that we're actually moving was probably much less than we should do better. And actually with the objectives of 120 at the high and us using metrodomes, because I mean, we got metrodomes on everything now, don't we? What do we have them on? What prompts do you guys have to be able to use now? You got the monitor in the AD mode, that has a metrodome. What else? The hand TV, it has a metrodome. And guess what? Your vents now have metrodomes. So that's all over the place, right? And then you can do an app for it. So, but that helps, right? And I've actually seen it if we're keeping the rate about what? What's the mean rate? Anybody? I guess between 100 and 120, so where do you think that might land you? About 110. Thank you, John. Yes, it is. 110 is the ideal target that we're shooting for. So there's a lot of components to the resuscitation, isn't there? Do you think like in NASCAR, when those guys go on holiday, they're not thinking about switching out tires and fueling tanks, are they? But when they come back to that first event at the NASCAR, boy, they perform that really well, don't they? I mean, in seconds, they're able to switch out tires and put fuel in the car and get the driver back out on the track. pretty quick. Does that take effort and practice? Probably does. I don't think that they come off the lake and go the next day on the track and they're all performing at that level. So I think we have to think the same thing, and we have to be mentally prepared, right? Communicate with just not our partner, but the first responders on what we want, because we don't get to train with them every day, but at least we have our partner that we can definitely communicate well with, and then do with those first responders that are there to help us, to drive them to stay in that lane and provide that care, right? And hopefully in a timely manner, which would then meet the hands-on, hands-off times, reducing those and providing that high quality. Are there some other measures that we can do to help decrease that 10 seconds? Anything that you guys do on a regular basis when you're resuscitating a patient? I'm thinking about performance-wise, okay? What can you do to do the things? What are the things that we have to do every 2 minutes? You're reassessing. What are you reassessing? Pulse. Do you look for a pulse when you start assessing for the pulse, or do you find it before you stop chest compressions? So you actually find perfusion based on the CPR, right? And then when they stop, you're already there. So if it continues, then you go, I got pulses, or I don't. How long does that take? That's pretty, so 5 seconds tops, right? So usually they give us at least 5 seconds, no more than 10 seconds, but you're able to actually do that a lot quicker because you're already there. So that's a good one. What about defibrillation? Is there a technique or something you're using there? Okay, so but do you ever consider pre-charging the defibrillator at that 2 minute? So you do it? Have you done it? What kind of response do you get from your first responders and stuff when you're charging the defibrillator? They get scared? What do you got to do? You tell them it's okay. Only sting for a second. All right, so there is some communication that you're going to have to provide that I'm pre-charging this, but you guys keep doing what you're doing. But what happens if it's not a shockable rhythm? What do you do with that energy? How do you dump it? You hit the charge button again? Yeah. So you charge, or you can change the energy and it dumps it that way too, right? Okay. That's good to know, right? Because you don't want it lingering, you know. Keep going. Keep on edge. But can you see that if I'm doing that pulse check like John's doing, and then you pre-charged, and we stopped, and we looked, and we did find it to be a shockable rhythm, how much quicker we could actually get that defibrillation off and back on the chest, right? That's the whole piece of getting it up to the 90-something%, right? Because if we're proficient on that and doing that, and that's the focus that when we're resuscitating that we should be giving those patients, right? So let's look at this scenario, because this part here is pretty neat, and I want to kind of get into, well, maybe, let's see, turn it on. That works. There we go. All right, so here's a scenario. Dispatch for an unknown problem, man down. Family member has called repeatedly without response. It's a 64-year-old male. Wouldn't come to the door. You actually seen him prone through the window, and you were able to gain entry, and you find the patient is unresponsive, pulseless, and apneic. What are we doing? Now, first of all, let me just say this. If he's in the living room, that's great for us because there's lots of room, hopefully. But that's not where we usually find them. Where's that usually at? Bathroom, yes. Between the wall and toilet, yes. So it's understandable that you're going to have to move your patient, right? Okay, so that's a key piece. But also, as you approach the patient, whoever's got the monitor, they're turning it on, right? So it becomes a marker of that patient time. Okay, cool. So tell me a little bit about what we're going to do. You're in the living room, so we're going to roll them over. Who actually is assessing the patient? You are, right? And so what are you assessing for as you're rolling them over? Yeah, so you see if they're moving, breathing, have a pulse, signs of circulation, all that is happening at one time. You're even probably even looking to see if there's some lividity going on as you're rolling them over. So all that's happening at the same time, right? And I get that. Um, so when we're thinking resuscitation at this point, because as we're doing this over and they're not stiff as a board and they don't have any of that lividity, you're looking for signs of movement, breathing, and you're checking for a pulse, and you don't see that, then you are starting chest compressions. Is that right? Okay. What's your partner doing? I heard monitor, and I heard yesterday iGel first. Which one has the better chance of survival for a patient that's in cardiac arrest with a shockable rhythm? Okay. And so putting stat pads on them is ideal. It gets confusing to me sometimes when we start that CPR after the assessment and I see them putting 4 leads on. That makes me wonder what's our intent. So just kind of keep that in mind, because usually if we're already done our assessment, we didn't see any signs that this patient was not viable, then we start resuscitation. Stat pads should be going on the patient first. That way, because in the earlier years, before this last update, we actually could do 2 minutes of CPR before actually defibrillating, but then they came back and said, wait a minute, we found out that it's better to actually provide defibrillation if it's a shockable rhythm as soon as the monitor is available. So if you have it there, put it on, analyze the rhythm, and provide defibrillation. Okay, all right. We'll talk about that here in just a minute. So pads are on that. Then what's the EMTs putting the iGel in? Is that right? Is that what I heard? Okay. All right. And then let me ask this question, because this was one that comes up. Vascular access, right? So what do you attempt first? What are you assessing for? Are you assessing where your IO is at? Are you assessing if the person has vascular access for peripheral IV side? Okay. All right. Thank you. AHA still recommends that. Okay. Yes, it's easy to put an IO in. It is more expensive. I'll make that note, but it is easier. But it's also better if we can do a site by a peripheral IV. I like it when I see people like John doing EJs. And Jessica on cardiac arrest. Rather than getting the IOs and then getting that vascular access. So that's good. That's good. Okay, so we got those pieces. Let's talk about this. Let's see if I got everything. We positioned the patient. We started chest compressions. We got the monitor, IV access, provided epinephrine. Oh, I got to tell you, as a QA piece, I noticed that you guys are really good at giving epinephrine every 3 minutes. That is amazing how you do that, because I never was able to be consistent with 3-minute intervals. Now, every once in a while, we're amazed because I find one at 3, 5, 6, 4, and it's all over, and I go, oh, that's me. That was more real. But it's hard for us to actually really document that based on when our epi was given, unless you got your HandTV app and you're hitting epi every time and then going back and looking at your times. But let me just throw this out there. Would it benefit? You don't have to do 3, you don't have to do 5, but could you pick 4? And then if you're actually doing 2-minute intervals every other, and now you're actually, I could see where 4 would actually be consistent with your checks, right? Especially if you're using like an app that has a prompt that's telling you every 2 minutes to check, right? Then you actually could be pre-drawing up and having that medication and giving it. The ideal situation is having it pre-drawn up, right? Because that's if you have your partner, and a handful of first responders at the door willing to rotate out, right? So that always makes it nice. And sometimes that happens, and I think that's where we get those really good 96%, 95% hands-on time, right? So let's go from those pieces there to the medication to talking about defibrillation. I want to ask you about that real quick. So you guys, hear the term in the ACLS as persistent and reoccurring, right? You know those terms. So what's persistent mean to you? It stays. What stays? VFib, pulsus VTach. So you shock it and it stayed in that rhythm. It didn't ever convert, right? It just stayed in that rhythm. That's persistent. Yeah. Reoccurring. So we shocked them out of it, and then the next time we came back, there it was again, right? So let me ask you this. What's the reason why we escalate energy? Okay. So you want it to be therapeutic. You want to cause conversion, right? So what if you do cause conversion with 200 joules? And then it's reoccurring. In other words, you defibrillated, you caused global depolarization of the myocardium. It actually put them into systole, and then eventually maybe work back to that VFib, right? Would we have to escalate that energy like the protocol says, 200, 300, 360, or could we stay at 200? Stay. Why? It worked, yeah. You know, there's this thing called myocardial stunning, right? Yeah, so that's the reason why AHA actually said, hey, don't do a pulse check after defibrillation, go right back into chest compressions, providing perfusion, because there's a chance that, yes, it might be an organized complex, but the stunning may prevent the contractual piece of it and actually starting to work. But after about 2 minutes, guess what? You might actually feel a pulse after some of that is resolved, right? And then, yay, we're on track. So if it was persistent, let's go back to that one. If we had where it was in VFib and we shocked at 200, it didn't come out, so then obviously you're going to increase that energy due to possibility of impedance, right? The size, the resistance between the pads and the heart and the flow of energy and the ability to actually globally depolarize it. And it's not working, right? So then you can escalate that. So if we think about our algorithm, there's a couple things that we're doing in that algorithm to try to convert that rhythm. Can you name some of them that we've done recently? Huh? Esmolol, yeah. So Esmolol, I think Sean, I told you there was, in that last meeting, it was 110, wasn't it? 110 patients that had needed to be defibrillated. The most cases of defibrillation of one patient, I think, was either 14 or 16. It was somewhere around there. Yeah, I see some looks on your face. Yeah, 14. Some of them were 5 to 7. But for us, use of Esmolol comes after how many defibrillation attempts of a persistent rhythm? 3. Yeah, 3. Out of that 110, there was probably only about 20, I can't remember. It was in the 20s. Esmolol was actually used. So we're missing the boat on that, and we need to think about that, because I have seen it work. I've seen after Esmolol been given that it went into a systole. So it changed the persistent rhythm. But there were some other things too, right? Because Esmolol came later, because we tried something earlier before Esmolol. Do you guys remember that one? The dual sequential defibrillation. How many times have you got to use it? You did twice? Oh, you're like you had the perfect scenario twice. That's pretty cool. Because you need 2 monitors, don't you? Yeah. You had to keep. Yeah. So how did it work? Did. Okay. All right. And you actually had both sets of pads doing it, and one fired and one other fired immediately after, and so you did it twice, and it worked on the second time. Okay. So energy does work, and there was some thoughts about dual sequential, but the thing is that we don't really have the opportunity. I mean, you were the one out of the whole room that had it, and you had it twice. But for the rest of us, we didn't have that opportunity. So we have to look at other options. And so some of those options came with vector changing, and that's something that we're looking at, all right, because there's some science that actually supports vector changing. And what is vector changing? That's just changing pad placement, right? What's the traditional, or what are we using for pad placement for our patients with the physio-control product? Yeah, anterior, posterior? Anterior, posterior, right? Thanks for, you guys are so live today. I appreciate that. It's anterior, posterior. Okay. So what's the traditional one, right? So if we had doing anterior posterior and we were up to the 360 and that didn't work, vector changing would encompass actually putting the other set of pads on in the other traditional position and then providing the energy. They're going to work. We're still working out the details on how that will be, but that actually shows better success than what we've seen. I guess probably because we don't have the opportunity for the two defibrillators and some of the systems that are out there using it. So we're definitely looking at that. So increasing energy when needed, right? Providing esmolol, do sequential if it's available, and coming soon, vector changing, right? So that's kind of interesting, isn't it, for persistent VFib. All right. So there's the algorithm. And if you look over to the far left, you see VFib, pulseless VTach. And up, huh? Yeah, kind of, right. It looks clearer on here, so I know it's clear, but there's a, yeah. So let me guide you. Yeah, let me guide you. VFib, pulseless VTach is on the left, and you can see where it starts off at the 200 joules immediately. Resume CPR for 2 minutes. There's the IVIO access. Then there's like a reassessment decision piece there that we're looking at, and then we're moving into epinephrine every 3 to 5. But we're going to do what? Every 4 to ish, yeah. And then considering after a few attempts of that and epinephrine, and that we still have a shockable rhythm, but we could consider amio. There's a 300 that's there, and we can repeat that at 150 in a few minutes. Then the question comes up, do we have ROSC? No. Did we possibly do dual sequential? And then was there a need to actually go to esmolol at that point? So that's kind of crossed over here. So we went through that one. So let's talk about asystole and PEA. I've actually seen people putting these two algorithms together and calling something that I saw that was PEA asystole, and it was a trend that was out there for a while, and hopefully I've fixed it because I haven't seen it in a while, but I was like, why are we doing this? And it's like, well, because we have to do CPR and epinephrine, and that's it. And I go, no, but your mindset, isn't your mindset different between the two? Isn't there some things that the causes? Okay, so in PEA, we're following this algorithm. Let's go over there, and we see, yeah, there's the CPR and there's the epinephrine, but there's a decision tree, and it's actually talking about is the QRS in the PEA complex wide or narrow? So let's kind of go through the narrow complex first. If you actually had cardiac arrest that you're resuscitating an individual and their PEA is a narrow complex and it's tachycardic, what might you think some of your probable causes might be? Narrow and fast. I mean, 110, 120. We're not an SVT thing, so let's not complicate it. Let's just say that it's a form of compensation. You know, it's thinking, huh? Fluid. Yeah, because AHA always said what? You know, PEA, the most probable cause of PEA. It was the right answer to this one was volume resuscitation, right? It was actually giving them. How do you volume resuscitate an individual in PEA? Hang a bag and just open it up. Thank you. Thank you. So you're aggressively giving your volume, right, in a shorter amount of time in that EJ to elicit, hopefully, a positive response, right? So that's great. So that was the narrow one because we're thinking volume, and that's good. What about bradycardic PEA? Sure. It could be drugs, overdose. What's the most probable one that's the easiest fix that we actually probably already fixed? or we're working on, because that's part of our key steps of actually going into resuscitation. CPR, monitor, airway. We put an eye gel in, didn't we? So yeah, so hypoxia, right? Hypoxia is a big one, but there's those other ones too, and I appreciate that, John. But I think that the nice part about it is we're already starting to fix some of those probabilities with our general resuscitation measures, right? So that's good. All right, so that kind of hits on those pieces. Let's go to wide. Now, it was probably about, I don't know, 2 years, 3 years ago, I think we actually added this part to the Y complex. And when I think Y complex, I'm thinking like idioventricular type stuff, right? And why are we actually adding calcium and bicarb to this algorithm? Huh? Electrolyte, so some metabolic derangement, right? Electrolyte imbalance. The most common one that we always focus on is hyperkalemia. Yeah, okay. So there are some other causes, but and there's reasons why they become hyperkalemic. We look at that. Now, the question that I have for you is there's 2 medications here. Which one goes first? Is there one that goes first and one goes second? You just do it all at the same time? What's happening? The bicarb. You love bicarb with a lot of things, right? It becomes an issue. I'm always doing that separate just because it doesn't like to play with other medications. But which one really? Is there? We use calcium, don't we? Now we have a calcium. I like calcium gluconate better, right? But so why calcium? So what is calcium doing at the cells? Well, we know it actually causes contractural force, right? Because we've actually seen, for those that are giving that, change in blood pressure for sure. But I would say that if you were giving calcium, you're stabilizing the cellular membrane. You're actually helping the channels be prepared for a shift, right? And so basically when you do that first and then you end up giving the bicarb, you're going to cause a greater shift, more efficient shift of potassium back into the cell. Because that's what we need it, right? It's outside the cell. It needs to go in the cell. And then with that, hopefully we can have enough where we can create What's going to happen to the QRS? What might we actually see during that resuscitation to know a positive change or effect with that medication? Narrowing. So the idioventricular complex actually tightens up, right? Yeah, isn't that cool? So, yeah, that's a pretty neat thing. You get to see that, then you know you're on the right track, right? And then hopefully, maybe you'll actually see some end tidal changes, and then you're really excited because you're thinking at the end of this 2 minutes, I might actually have a pulse with this, right? So those are definitely a positive change, and we did that because we had actually seen in the years prior where we missed that. You know, we always taught it in ACLS, the H's and T's, right? Think about this. But I think we got caught up into the scene and what was going on and the mechanics of the cardiac arrest that we missed that. So we added that to it, and we want you to use it. And I've seen a bigger change in the use of that for those Y complex rhythms. So good. Okay. All right. Questions? What rhythm is that? V-fib, right? There you go. Got to make sure we got our basics down. I've talked ahead of the slides a little bit, so we'll catch up. If you look here, this is just showing the esmolol and the dual sequential defibrillation and the epinephrine and the antidysrhythmic, and kind of hitting on those pieces. So I won't repeat this. There's the vector changes that we did. There's that PEA. There's that Y complex. Tell me what you see whenever you see a development of hyperkalemia. What's the first thing you start seeing to change? So you start seeing T wave changes the T waves become more tall, right, than the rounded ones that are more ischemic, right? acute coronary syndrome type. What else starts to happen with that? Do you remember what happens to the PR interval? It starts to widen, right? And at the same time, when you see that widening, what happens to the QRS? It starts to widen too. Eventually, you lose the P wave, so then there's no PR interval, and then there's this T with this wide QRS. So what's our attempt is that as we see the correlation of the potassium, not in the cell but outside of the cell, we start to see that change. So our whole goal is just to try to shift it to bring all that back together. So good deal. So guess what? You ended up